So with that, I want to introduce a colleague and friend of mine, Margaret VanVliet, who is the Director of Oregon Housing Community Services. And for those of you who are not familiar with Oregon structure, Housing Community Services is our state entity that administers our Community Services Block Grant and all of our federal funds, our weatherization funds, and other state housing funds. And Margaret has been a tremendous ally and champion of the work of community action. As well as housing, which community action was a new arena for her to come into. But I think, it's been 3 years now? 4.5. Wow, time flies when you're having fun. But over the last 4.5 years, she has been a quick student and a diligent student on the issues of community action and ending poverty, and really working at the state level to provide that intersection between housing development resources, and community action. And so I'd like to also co-sponsor of this event, and I would like to welcome Margaret up to introduce our morning speaker.
Skills so far. There we go. Good morning. Very happy to be here this morning, and pleased that yesterday seemed to have gone so well, and I'm really hopeful about how we're going to proceed through this day. I want to be really quick to give our keynote this morning plenty of time to share his thoughts. So just really a quick introduction. David Erickson, I want to call him Dr. Erickson, but he said not to. He is the director of the Center for Community Development Investments at the Federal Reserve Bank of San Francisco. He earned his PhD in history from the University of California at Berkeley, and his book on the history of community development, The Housing Policy Revolution, Networks and Neighborhoods, was published by the Urban Institute Press in 2009. A couple of reflections about this morning's speaker. First, he is really an expert. His little bio that I was given does not do justice to his expertise and his deep knowledge of housing policy in this country. And if you have not noticed, we are in the midst of a housing crisis, certainly in this city, in this state, and I guess really all over the country. And so to understand housing policy and how it has evolved in this country over time, I think is really important to understand and to look back and think about the context for where we go next with questions of housing development and housing policy at the federal and state levels. I think the other piece that you talked a lot about yesterday, and we're going to go there in more detail today, is on this question of social determinants of health and the intersection of housing policy and housing development with health, and these questions of, does the zip code into which you're born influence your life outcomes? And I think we know from what we can see today, the answer is yes. And so to unpack that and think about what does that mean for how we develop policy going forward, I think it's really important. And finally, I want to just say a very quick word about the Federal Reserve Bank of San Francisco. You might say, wait, what? What's the Federal Reserve Bank of San Francisco doing at a poverty conference? How does that work? And so let me just reflect, as a former banker myself, that I think it is really important to understand that the flow of capital has a huge influence over where and how and what kind and for whom housing is developed in this country. And so the Federal Reserve Bank has an enormous influence on those policies that drive the flow of capital. So I think we're very lucky, particularly in this region, to have our Federal Reserve branch be so involved in these issues of community development and the intersections of health and the well-being of families. So with that, let me invite David Erickson to speak with you this morning. Thank you very much.
Thanks for that. And I noticed you had a copy of my book, which means I now know because my mother bought one, and now I see you bought one. So I see it sold 2 copies, I think. So Well, thanks, everybody. Thanks for having me here. And it's always a thrill to be back in Oregon, and particularly in a place like Oregon. I get a chance to speak to a lot of communities around the country and around issues around anti-poverty work. And when I'm in places like Cleveland or Detroit or Las Vegas, it's a different message. You know, it's kind of it's harder. But when I'm in a place like this, you can almost feel the energy in the room, because what you have is in Oregon, you have high capacity state, local government. You have high capacity community-based organizations. And you have great need here, but it's not overwhelming. And so I just have I do believe that the breakthrough in some of these new business models and these new ways of doing anti-poverty work are going to happen in places like Oregon, because you guys get along, you know each other. It's not like Los Angeles, where everyone thinks they're right and you can't get anything done there. So I'm very much I'm excited to be here and learn from you today. I should also say, I want to just draw attention. Ian Galloway is going to speak to you next, and it was a great sacrifice to let him leave San Francisco and move home back to Portland. He is really the backbone of our organization and is a leader in our field in so many ways. And but we agreed to this request of his in part because we wanted to have a presence here in Oregon and have somebody who could just be so we wouldn't have these occasional visits. We would have someone here full time. So Ian's at our Portland branch, and I hope you get a chance to reach out to him. Before I jump into my remarks, I do want to just kind of make a couple observations about where we are in this conversation. About you mentioned housing, which was really a really important concept that is beginning to morph into these other ideas about the social determinants of health, and we're starting to, it's not clear where this is all going to land, but just to give you a sense of how remarkable the conversation is at this point, we just recently had a big conference in Los Angeles where it's a nationwide conference for bankers who do mostly affordable housing lending. They're CRA-motivated bankers, 1,500 people in the room, 1,300 of them were bankers. And Risa Lovizo-More, who heads the Robert Wood Johnson Foundation, the world's largest foundation dedicated to improving health, came up to the podium and she said, it may strike you as odd that a doctor is talking to a room full of bankers, but I want to make it clear that you understand that you are the most important health workers of our time. And it's just remarkable, and that's going to get into some of that. I think that there those who are trying to improve health, those who are trying to reduce poverty, those who are trying to make a fair and more just society are beginning to see that they are really linked in the work that they do. And I think it's just a very exciting time. So let me jump in here. So this is a kind of, you talked about the social determinants of health, and this is such a strange idea that health is not healthcare, and it took me a long time to kind of unlearn that. You know, it kind of reminds me, my husband was traveling in Guatemala, and he's fluent in Spanish, and he was with a friend who's South Asian, but she kind of looked Guatemalan a little bit, and every time they would go ask for directions or something, and he looks like a Mormon missionary. I mean, he's very, blonde and whatnot. Every time he would ask the question to the person on the street, can you tell me where the train station is or where the bus station? And they'd look at him, and they'd respond to her in Spanish. And she's South Asian. She doesn't speak Spanish. She had no idea what they were saying. And I kind of feel like this idea that health is not healthcare is sort of like that. I mean, every time you say health, people think medical care, but that's not what it is, right? And when you talked about this a little bit yesterday about the social determinants, and this is a study by Mike McGinnis on the causes of premature death, and you'll see that this one piece, only about you would think that medical care would have a big contribution to that, whether it's bad medical care or lack of access to medical care, but it turns out it only accounts for about 10% of the number of people who die prematurely. Now, this study has been run hundreds of times in different ways, and sometimes the percentage is 10%, sometimes it's 20%, but it's always this small percentage, right? But overwhelming, you see other things, environmental exposure, maybe you're too close to some kind of a source of toxins, freeways, et cetera. Social circumstances, the number one leading indicator for health for a senior citizen has nothing to do with a medical measure. It's the degree to which they're socially isolated. And we saw this, for example, in the heat wave in Chicago in the 90s. The behavioral patterns, of course, we all need to exercise and eat right and do all those other things, but it's hard to do those things if you live in a dangerous neighborhood, or you don't have access to fresh food, or all the other things that help you live a healthier life. And then I think you talked about epigenetics yesterday, which I'm so excited about because that's one of my favorite topics. So this idea that this is when Jean-Baptiste Lamarck was right. That these ideas that maybe the giraffe does lengthen their necks, in order to reach the tree leaves. And then in the same way, there are genes in your body that are turned on or off based on the neighborhood you live in, based on the environment you are in. So what you find is that, in fact, the things that are driving your health are way outside of the doctor's office. Now, I want to go through a few demographic, you probably talked a little bit about this, but I'll go through these quickly. But so if health is not medical care, what is it, right? And this is a slide that's showing you on the left side are people, the left bar is men on the left, women on the right, and the left are high school dropouts, life expectancy, years of life expectancy at age 25. The bar on the right, the far right, the fourth bar, are college grads. And you'll see that there's this is a laser. What's that? Oh, that's okay. Maybe I'll just stay. So, well, you can see that there's about a 9-year difference in life expectancy for people who drop out of high school versus those who graduate from college. So, and as I get to the point where I don't have that many decades left, I'd be super pissed to have one taken away from me. So, I mean, that is really upsetting. What else is health? Health is income, right? So I'm going to show you a few slides here where there are, again, 4 bars, but in this case, the bar on the far left is those who live under the poverty rate. That's about $20,000 for a family of 4. Of course, you guys are human services providers, so you know all that. But the next bar over is between the poverty rate and 2 times the poverty rate. The third bar, is 2 times the poverty rate to 3 times the poverty rate, and the final bar on the right is 4 times the poverty rate or higher. Okay, so those are the income bars. We're going to go through a few slides where we're going to use those. This is just on children. The graph on your left shows percentage of children that are in good health, and you'll see it's almost 4 times more children reporting poor health that under the poverty rate as those at 4 times or higher of the poverty rate. And similarly, you see the chart on your right shows this is childhood obesity, and it's double the rate for low-income kids as it is for kids above 4 times the poverty rate. So you start seeing that health is income, education, health is income. I also want to draw your attention to the fact that this isn't just the poor and everybody else, right? There's a gradient here. It's you. Every step of the way makes a difference, and so and you'll see this again and again. You saw that with education. You see this with income. Again, here are the same bars, right? Under the poverty rate, et cetera. And on the left, these are people with that are reporting poor health. And what I have here are black, non-Hispanic on the left, Hispanic in the center, and white on the right. And you'll see low-income people in all racial categories are in bad shape. And I want to also draw attention to the fact that poverty is also concentrated. So about 1 in 4 African Americans and Latinos are living in poverty, as opposed to 1 in 10 white and Asian Americans. So I just want to this is one of those weird situations where it's not just about race, and it's totally about race, right? Now I want to shift a little bit, just shift our thinking. So I'm going to step away from the demographics and think a little bit about geography for a second. If you just Google Raj Chetty and New York Times, you're going to get a flood of articles that I'm sure you're all very familiar with. But he's just really revolutionizing how we're thinking about poverty and opportunity, and how it manifests over space, and how communities contribute to opportunity and better health. This is about showing economic mobility in the U.S. by region, and so the United States does not fare that well in terms of economic mobility. Economic mobility is often measured by what's the likelihood of being born in the bottom quintile and ending your life in the top quintile. And it turns out that the country with the best mobility is Denmark, and we're way down among rich countries, not about in the middle somewhere, which is why the sort of running joke is if you really believe in the American dream, you have to move to Denmark, right? But the United States is a continent-sized country, right, which really makes it complicated. And so when you disaggregate the data over space, you find a newer, it shows different patterns that are important to understand. So in the case of, it's interesting that Salt Lake City and San Francisco, two cities that are, you couldn't imagine, two more different places, have Denmark-level mobility, right? So there's something going on, and if you're in the Southeast, you're in trouble. I mean, that's a real. But you can see even in Oregon does pretty well on the coast, less well in Eastern Oregon, but still pretty good overall. But the point I'm trying to make here is that here, so often when we talk about anti-poverty work, people say, well, it's, well, now everyone's talking about bad trade deals, right? That's the big thing that's in the elections right now. But this is what they say, well, it's bad trade policy, it's globalization, it's technology that's hollowing out middle-class jobs, it's insurmountable. It's structural racism, it's a broken Congress. And the point here I'm trying to make is that here's all of those forces affect all of these places, and yet they're still radically different outcomes, which is, I find, very heartening, because I find there is agency here. There's a way in which we can assemble the building blocks and the relationships and the interventions in a way that's more effective, given what we have today, right? Okay, so again, talking about geography. So we've had, next week we're having a conference at the Philadelphia Fed and the University of Pennsylvania School of Public Health on the What It's Worth book, which you have here on your tables. And that will be our 27th conference that's been focused on anti-poverty and improving the social determinants of health that we've done in concert with the Robert Wood Johnson Foundation. And in these places we often go, we try to do some kind of an infographic that shows how life expectancy varies over the place where we're having the conference. I pulled this one. So we've done this in a lot of places. New Orleans, the difference in life expectancy is 25 years, ridiculous. In other places, it's varying degrees of bad. But I like this slide because this is the Twin Cities where kind of everybody's above average. Like this is like a very very low poverty rate, very capable local institutions. And still, you'll see on Interstate 94, there's a gap. You see at sort of the bottom left corner of 13 years in life expectancy between two off-ramps of Interstate 94, right? And what I like about this is the Minneapolis Fed, they do a better job at getting sort of media attention than we do. So they had the local television station come in and they were doing a segment on this conference, this Healthy Communities Conference, and they interviewed people on those two different off-ramps. And they said, to the guy on the far left, in the neighborhood that's got the lower life expectancy, said, well, what do you think about that? And he said, well, what do you mean, what do I think about that? I think I'm going to move to that other neighborhood is what I think. So like, but all of that's just to say, right, that your zip code is more important than your genetic code for your health. Your location matters, the place matters. And the things, it took me a long, long time. I mentioned my Boy Scout husband, but he's also a public health professor and a pediatrician. And you would think I would have gotten this earlier than I did, but it really is, it finally kind of soaked in, which is your body is the sum record of your challenges and your opportunities, right? Your challenges and your opportunities. So when you live in a place where there are a lot of challenges and few opportunities, you're going to live a shorter life. You're going to be poorer. You're going to have fewer educational opportunities, and that will affect your health, right? And the things that we can control that could turn places that are health detracting to health promoting are within our power to do that. So whether it's high quality schools, I know charter schools are kind of controversial, but you've got some really interesting innovations here in Oregon around the community schools movement, which I think is really exciting. We can put grocery stores in food deserts. We can create jobs with small business financing and workforce training. We can build safe, decent, affordable housing that's service enriched for people who have some special needs, perhaps. You do a great job here in Oregon around transportation, but we can do a better job in terms of finding the resources necessary to sort of pull parcels out of the marketplace around transit sites, transit stations, so that we can preserve those for low-income people to have the same access to opportunity that that transportation brings. And parks and playgrounds, we're not very good at that in community development, but I think there are other people who could do that work. Those of you, I know some of you are human services, and maybe you don't work as much with community development, and I just wanted to just draw attention to the fact that community development is a sector that does focus a lot on real estate development, but we are definitely trying to figure out how to make better ties to our friends who do more focusing on people. So we have to bring the people and place people need to come together, and we're working hard on that. We think focusing around health is a good way to do that. But again, community development really does focus mostly on affordable housing, community facilities, but there's a kind of a killer app with community development, which is this harmonizing of multiple funding streams, whether it's philanthropic dollars, grant dollars, government subsidies, and then the below market, the public program-related investments, or maybe somebody, a high net worth individual who's willing to have a slightly lower than market rate return on their investment, or bank capital, or investors who just want a regular return, but would like to focus some of their investing on their community. And being able to create those kind of financing cocktails or those fund structures that have the different layers of different types of capital is really something that community development has learned how to do over the last 30 years. And the other piece is this idea that you can sort of tailor an intervention at the local level, but tap into larger systems and do those local interventions at scale. So it's one of the few policy sort of interventions that I know of that can really get to this. So just one quick example in senior housing, for example. So senior housing, in the early days, in the old days under HUD, was a program called HUD 202, which is always so romantic in terms of their choices for titling programs. But the HUD 202 program was basically the idea was to save money. They'd come up with one design for the whole country, right? And they basically so they hired Joseph Stalin's architect to come to the United States and design housing that looks a little bit like a cross between a hospital and a prison. And it looks like, and it's big. It's these big structures. So in my neighborhood, in the Mission District in San Francisco, there's cute Victorian, a spaceship prison hospital, cute Victorian, right? So it just has nothing to do with the local environment. It's a terrible program. I mean, terrible in terms of it not meeting local needs. Contrast that with how we do this today, right? So under the low-income housing tax credit program, affordable housing developers really think very closely. And in this book that no one bought, other than Vicky, I talk about this one group in the Hayward area of San Francisco Bay Area, and Eden Housing was building housing for. It was in a Japanese American community, and it was senior housing, so they're mostly women, and the architect was like, well, we want to really reflect your culture and this and that. We want to make sure we understand what your needs are, and they're like, yeah, we don't care about any of that. We're tired of American kitchens because we can't reach the counters in these anymore. So we want the counters low, And I just think that's awesome because in that example, this was back in the day of securitization, that was a German pension fund was providing the capital that went into creating the mortgage, that went into creating the housing that was absolutely tailored to the local need, right? And I think that's that is a really important concept of what community development is able to do. Tailor to local needs, but tap larger sources for scale. So it's big, right? It's big. It's about at least $150 billion a year. About $20 billion in subsidies come from the federal government in terms of low-income housing tax credits, new markets tax credit for small business, and the parts of the CDBG that go to community development. But that leverages a lot of money around the CRA-motivated banks, community reinvestment-oriented banks. And increasingly, we're starting to see socially motivated investors, too, who really want to invest in their local communities and improve them, and they just don't have the means to do that yet, and we're trying to figure out a way to connect them to those investments. Now, there's I mentioned some of these things, and because you're familiar with them, I'm going to skip over this, but it's affordable housing, business development there, small business development in the top right, charter schools in the bottom left, bottom right rather. But there you get a sense of the kind of beautiful things. And before I went back and got my PhD, I did affordable housing finance, and my rule was, would I be proud to have my mother live in this apartment building? That was my rule. If I couldn't answer yes to that question, I would not make the loan. And there are 3 million units that look like the ones in the bottom left corner, and they're beautiful, and you would be proud to live in it, and your mother would be proud to live in it. And in fact, in the book, I interview a woman, and she says, yeah, I love living here because when I order a pizza, they're not afraid to deliver it to me. Think about the health effects of that. That woman is proud of where she lives. She's not ashamed of where she lives. She feels a sense of safety there. And that translates into a longer and healthier and more productive life. So we're definitely making progress on this idea of, so community development is getting better, human resources are getting, human services providers are getting better, we're all getting better, but we've got a ton of work to do. And we did this book a while back called Investing What Works. Ian was a co-editor with me on that, along with our friends at the Low Income Investment Fund. And that was a pretty exciting project. And there was just a lot of sort of people beginning to recognize each other as being a tool for helping achieve their goals, and solving someone else's problem was solving your own problem. And I was really struck by one of my favorite lines in the book is by Risa, who I've already mentioned, writing that she says, we're likely to look back at this time and wonder why community development and health were ever separate industries, right? I mean, just a powerful idea. And when she came to the conference in LA just a couple of months ago, she said, I'm here to tell you that time is now. And we are now committing hundreds of millions of dollars from the Robert Wood Johnson Foundation to invest in community development and human resources and human services in order to improve health. So we looked at a lot of examples in the book to try to figure out, what are some of the bright spots? What are the areas where people are really making a difference, really turning communities around? And we looked at places like the Harlem Children's Zone, purpose-built communities in Atlanta, Neighborhood Centers Inc. in Houston, lots of interesting models, and we found they all had these sort of elements to them. They're all sort of common, which was they had trust from the community, right? That is you have to have it's a non-starter if the people that you're trying to serve don't trust you. You have to be cross-sectoral. We all know that. You have to, health has to work with community development, has to work with human services, with education, with public safety, et cetera. I mean, that's key. You have to be place-based. You have to love Harlem, or you have to love the Pearl, or you have to love the Mission in order to get people to behave differently, because that's not the way the world works. I mean, it's very hard to step outside of your business model, your comfort zone, et cetera. And being passionate about a place and about a community is really helpful in keeping everyone together. You have to be data-driven. Do more of what works, do less of or shut down what doesn't work. You have to be really ruthless about that. And you need some kind of a backbone organization. We call it the community quarterback in the book. The health people call it the integrator. The FSG consulting people call it the backbone organization. Very different names, but you always need that. What we have found, too, in those interventions, there were two other elements that were always present. One was that there was a charismatic super genius who had a close friend who was a billionaire, sort of behind it. So we know that's not possible. So what we're trying to do, I'm just convinced, there is just no doubt in my mind that there's leadership everywhere, and that we can train that and we can foster that. There's also no doubt in my mind that we have enough money. We do not need any more money. We can reverse engineer the billionaire too, and Ian's going to talk to you a little bit about that, ideas along those lines in a moment. But there is, it really does kind of go back to my mantra that the status quo is stupid and expensive. That there's plenty of money, but it's just being spent on the wrong things. And we're getting a lot of traction. So this idea of we can use money to invest in the upstream determinants of health, that we can sort of intervene into a community early and have great outcomes. There's a lot of movement on this idea. And so I just wanted to put a few of these examples that are sort of taking us in that direction. And there's a lot of money flowing to this now. I mean, just to pick one, the Healthy Futures Fund, I'm on the advisory committee for this. It's a $200 million fund. It's comprised of three partners. The Kresge Foundation is providing the most risky capital. the first loss capital, in a grant. The Local Initiative Support Corporation, LISC, is providing a lot of the technical assistance and some other sort of below market but not quite grant level funding. And then Morgan Stanley is coming in with 87% of the rest of the financing at market rate. But what's interesting about it is if you apply to this fund and you build a federally qualified health center, for example, you can't just build medical exam rooms, right? If you're going to build a clinic in a local community, you have to make sure that clinic embraces a community-oriented primary care model, or in other words, that clinic has to adopt the whole neighborhood as the patient, right? And so it's beginning to show what we're finding is through funds like that and the many others that you see, we're starting to shift incentives to get people to not only think differently about how they do their intervention, but actually do it differently and build differently. So we're making, again, the fact that you talked about social terms of health yesterday is pretty exciting. The fact that the funding is beginning to sort of now begin to follow up and recognize that understanding and act on it. But we are up against a serious problem. So just to look at that first number, 3,500 census tracts in the United States have poverty rates above 40%, right? And those glom together in different ways. They're probably about 900 communities across the country, but it's a huge, huge problem. So we think in order to get to the scale that we need, we have to really focus on systems change. And this is where we get to that sort of reverse engineering the super genius and the billionaire. And part of it is that I don't know why this is this clip, the scene from the Matrix movie, but I always think there's like this moment, like if you had those like Matrix glasses on, if you could just see like who are all the partners, where are all the dollars, how can we get all of them to come together for the greatest impact? I really do believe we could end poverty in the next 25 to 30 years. It's in our power to do that. And I think there are places that are already sort of on the vanguard of that. I think there are a lot of hotspots. So I do believe Oregon's a hotspot. I think Hawaii is a hotspot. I think Lincoln, Nebraska is a hotspot. I think the Twin Cities are a hotspot. There are a lot of places that I think will be very close. Salt Lake City is a hotspot where they will be able to combine local resources with a smart intervention that can really get results within the next decade or so. But there are things we need. So I mentioned the What Works book. The second book in the series, you have the What It's Worth book, which is the third book in the series. The second book is What Counts. And all these books are free, by the way. So if you're interested and you'd like to share this with some of your colleagues, please just Google the title and the Federal Reserve Bank of San Francisco, and you'll get this. But and then you can order the books online. But we really do think that data is important. Data is important for a lot of reasons, not only just because it tells us what's working, what's not working. It also builds trust with the community that shows that what we're doing is helping. It also has the ability to sort of identify and maybe even, and this is a tricky term, but to monetize some of the savings that we can achieve by avoiding emergency room visits, by avoiding incarceration, by avoiding special education slots in schools. And that's something that I think is really necessary if we're going to do what I think is where we're going, which is creating a market that values health. I think this is a big idea change that's on the horizon, where basically there are people who buy health, and people who buy health are Medicare, Medicaid, United Health, health insurance companies, medical care systems, hospitals, the Robert Wood Johnson Foundation. I love that there was one nun. She's on the board of one of the Catholic hospital systems. She said, we all believe in God, but we're all funded by the Robert Wood Johnson Foundation, right? But they've got a lot of money, right? So they want to buy health. You sell health. What you do makes people healthier. We talked about that earlier. But the interventions that you do deliver help. What we need to do is figure out, how do you measure that? How do you buy a unit of health improvement, right? And how do we get people to pay for it? And how do we encourage tool makers to connect the buyers to the sellers? This framework, by the way, is all Ian's. We had a conference on this in New York City, where the co-sponsors were fascinating. It was the Federal Reserve, the American Academy of Pediatrics, the Centers for Disease Control, Morgan Stanley, a bunch of nonprofit banks, the New York Academy of Medicine. I mean, it was just this crazy group of people. It was a terrible conference. I mean, you're lucky you didn't go, because nobody quite got it yet, and maybe we didn't understand it yet. But they really do think there are buyers of health, sellers of health, and the tool makers like a Goldman Sachs creating a social impact bond to pay for early childhood interventions in Salt Lake City. That's a tool that connects buyers to sellers of health. But we need the data to be able to prove it. And turn it into a commodity of sorts. And again, like, I'm a Marxist. I'm not a market apologist here. I'm just saying that I think this mechanism is really necessary. I hear all those whispers when I say that, but you know. Right. Karl Marx is a genius. I mean, his assessment of history is I mean, he's a brilliant historian. I mean, there's no two ways about it. Is this being recorded? Is this? I don't know. So, but I do believe that a quasi-market that value is the only thing that is of the scale that can get us to where we need to go, because every place is different. Every place has different sets of assets. Every place has different types of problems, and there's no program that's facile enough to sort of do what needs to. When people say things like, "Oh, well, education is the answer," I'm like, what are you talking about? Of course it's important, but it's part of 10 things that have to happen right. You know, simultaneously, no one thing works. And I think the market is the only thing, a quasi-market, right? This isn't a regular market, but it's one that the government creates in some ways, is the only thing that has the power to sort of coordinate all of the different actors around a common outcome goal. And I think policy is really important. And here, things like choice neighborhoods, promise neighborhoods, there are a lot of really smart, I mean, we're trying to do that, but these are not as successful as we'd like them to be. And I think the real game changer, by far, is the Affordable Care Act. And the work you're doing here around coordinating care organizations is the vanguard of that, and everybody's watching you because it is so important. But you see, I mean, we spend $3 trillion a year on medical care. 80% of that goes to chronic disease. Most chronic disease is avoidable, and most chronic disease is born out of those neighborhoods that we talked about earlier. So if you fix those neighborhoods, you save $1.5 trillion. So this is not a small marketplace. And finally, I just say, this is my last slide, and I just say, you know, this is a market that, if you want to create a market that values health, I think there are lots of ways to do that. Increasingly, you're finding medical care providers and insurance companies are being paid per person per year to keep people healthy. The minute that happens, everyone starts saying, well, we know health happens in neighborhoods. How do we fix the neighborhood? Right? That's Kaiser asking that, not the Mercy Housing or, you know, some people who are in that business. So we're already seeing a shift there. We're also seeing a shift around things like pay-for-success financing. Ian did a really groundbreaking set of essays on this. If you Google that concept, pay-for-success financing and Federal Reserve, you'll get that collection of essays. We're working on the 4th book. What It Costs, I think, is the name of it. I'm not sure what matters, maybe. I forget. It's got to say what in the title, because my boss says it's the whatever series, you know, of books. But this is the last book, and this is how do you pay for this cross-sector place-based work? How do you sort of turn this into a real marketplace? And so we're doing that book now. It'll be out in the first quarter of 2017. But I think there are lots of ways, whether social impact bonds, whether it's pay for success or contracting, whether it's population health business models, that are going to start shifting a lot of money into the space to solve social problems. And I think this is important not just for us, not just for the United States, for the whole world. I mean, I think there are a lot of other places that are struggling with the same phenomenon, and I think we've got something to teach the world if we get this right. So that's my talk. I feel like I went on too long. I just like talking to you guys, and I just feel like, but I'd love to sort of take some questions and hear what you're thinking, and if I have time. Do I have time?
You have time.
Margaret, do a little recap, and then we take some questions.
Sounds great. Good.
Well, I don't want to take time away from what you want to hear. I think this is very timely for us for a lot of reasons, and I think one of the pieces, I could zone in on a lot of pieces. One of the pieces I want to zone in on for a minute is this data question. And I know you talked a lot about that yesterday. It's a huge theme for us in the agency I run. We're trying to become data-driven. We're trying to really get savvy about not just counting widgets and outputs and people in apartments, but we're really trying to sort of think about what are the outcomes and how can we in state government do that better, and what role should we play in that arena. And so I would really appreciate hearing from you. Is there a state that you know of that does, just among all the things you touched on, that data piece well, that you think we should take a look at and yeah.
Yeah. So turn it off.
And actually, I want you to have the podium because I think that
Okay.
I think that makes more sense.
So I do think there's I think there's the work that there's success measures, there's the neighborhood indicators project, there's the county health rankings. There are a lot of systems that are in place that I think our policy maps work around some of the sort of what are the economic drivers in a local place. I think there are a lot of examples that are good. I don't think they're good enough. Okay. And so I don't think there's one place we can really point to yet, although you're seeing some breakthroughs. So for example, it's interesting the way I think Robert Johnson's about to come out with mini health measures at the zip code level soon, and that's going to be really helpful. Just life expectancy alone could be the one driver because everything sums up to that. So I think that could be a breakthrough, and that should be available within about 6 months.
Let me see if I can sort of scan the room and see if I know there must be questions or observations folks in this room want to share, and I can be kind of the facilitator here and field your questions, and he can, over here. Good, Jackie, get us started. And if you, when you ask your question, if you go ahead and introduce yourself.
Jackie Shad from, I'm with Access. We're in Southern Oregon, Jackson County. And we are semi-rural, small city. So one of our questions always is, how do we take the stuff that works in big cities and make it work in smaller places when we have municipalities with no resources and counties with no resources? And there's sort of corresponding question to that, really, which is, it's hard to change a life expectancy statistic in a 3-year funding framework or less.
No, that's a very good point. That's a very good point. It's interesting. I mentioned we had 27 of those meetings bringing together health and anti-poverty. We've only had one focus on rural issues, and that was in our branch in Helena, Montana. And the challenges there are really different. There are advantages, too. One of the things that's really powerful is that if you are trying to get you're trying to be cross-sectoral and comprehensive in your approach, you need to get everyone around the table. You can actually get them around a table, right? So that's an advantage.
Jackie makes that exact point when I visit her in Jackson County. It's like we all know each other. We rely on each other. So I think
Yeah.
that's a really important asset.
But you don't have access to things like tax increment financing or a lot of CRA-motivated banks, or and one of the things that we're trying to change with CRA, although it seems to be taking forever, is to release some of what we call the assessment area focus. It used to be that $200 billion or so a year that goes into CRA lending and investing. It was trying to say invest in the places where you take deposits, and it was focused on where you had a bank branch. And so now that everyone does their banking with this, it's less of that going on, and you have these weird circumstances where Goldman Sachs has a bank in Salt Lake City, and there's tons of money looking for deals in Salt Lake City, but there's nobody looking for rural deals because they're not in assessment areas. So that is going to change, I think. Janet Yellen has really kind of taken us to task and saying we need to modernize CRA, make it more effective. And so I think you're going to see something within her tenure. She's only got 2 or 3 years left. She is the nicest person in the world, by the way, just to let you know. She's the second most powerful person on earth, and we'll meet you in the elevator and ask you how your last vacation was. And I mean, she's just so, and she's committed to these issues. So I think you're going to see some change on that. I think we need to make better partnerships with organizations like USDA and these other sort of entities that just have deep connection and funding capability in rural areas. And then also, there's even rural areas. I think there's a case to be made in terms of some of the links to the hospital systems and the local. I mean, these are big employers and they're big. They have real resources, and I think if we could start blending some of these together, USDA with some bank capital released from CRA restraints with some hospital monies, you could start seeing a flow. But one thing to keep in mind is, our friend Robin Hackey, she's now at the Kresge Foundation. She was formerly at Living Cities, but she calls it the capital absorption problem, which is a terrible term because no one knows what that means. But I'm a historian, so I don't understand, even though I work at a bank regulator. But I'm like, look, explain to me, like I'm a 2-year-old, what you mean by that. And she said, well, it's basically like this. Capital is an airplane, and it's flying around, and it's trying to land. But there are all these trees and bushes on the ground, and you need somebody to clear the brush. And when they're done clearing the brush, and that's usually done by foundations or people who are willing to take the highest risk. And then someone comes in and kind of smooths it out and paves the tarmac, and that's usually local government or other entities. And then finally, you need somebody to kind of build the airport, and that's usually capital from banks or market rate capital, insurance companies, other big institutional investors, pension funds. And when you get it right, then the plane can land, right? And too often, rural places do not have a landing strip. So we need to work on that too.
Right here. Thank you.
Hi. You mentioned...
Can you introduce yourself, sir?
I'm sorry. I'm Keith Fan from the Multnomah County Poverty Action Council. You mentioned the fact that banks are concerned about affordable housing.
Yeah.
How are bankers working to address the problem of arbitrary rent increases by landlords?
So this is such a difficult question. It's one of the problems we have is there are larger forces at play that are pushing up those rents, and so we have an essay. We did a working paper on issues of gentrification and displacement just recently, and if you just Google those words and the Federal Reserve Bank of San Francisco, you'll get it. It's very good. It's a comprehensive analysis of all the studies that have been done on gentrification and displacement. And I'm afraid to say the conclusion is there's no silver bullet here. There's no one thing that helps. There are a series of things that seem to help, whether it's inclusionary zoning or land banking or land trusts or affordable housing development or using new resources from other sectors like the transportation sector to try to build more affordable housing near transit and things like that. So there's a lot of strategies that taken together might make a dent. This paper also shows that in about 92% of census tracts, there's no price pressure on rents. And so this is a problem for sure, but it really is, it's more of a Portland, San Francisco, Santa Monica, New York City problem than it is a Baker, Oregon, or a Fresno problem. So I mean, so we need. I mean, not to be. I don't want to be glib about that, but it's not a problem that's affecting the whole country similarly.
Over here, yes.